Welcome to This Month in Type 1 Research. Please check the description for the original sources, and all content is general in nature and should not be considered medical advice.
It is genuinely good to be back. And I have to
Good.
say, looking at the sheer volume of papers that have come across our desks for January 2026,
Mm.
I'm getting a very specific feeling.
Oh, well, yeah.
You know those moments in science where things stop feeling incremental and they start feeling, well, structural?
Structural. In
Y-
what sense? Because usually we're looking at these small steps, a slightly faster insulin here, a pump software update there. But looking at the stack for this month, it feels heavier.
Heavy is a good word for it, in the sense that the ground is actually shifting.
Right.
For the last 10 years, we've been in this rhythm of refinement, just, small tweaks.
Right.
But this month, I was reading through these abstracts last night, and I realized we're seeing a convergence.
I felt that too. It's like the silos are finally breaking down. For the longest time, Type 1 research felt sort of split into these really rigid camps.
Exactly.
You had the gadget people over here, the engineers, the mathematicians writing algorithms, the hardware folks,
Right.
and then way over there, effectively on a different planet, you had the biologists and immunologists trying to figure out the immune system, and they rarely seem to talk to each other.
Precisely. The whole silicon versus the cell debate.
Yeah.
But this month, it feels like those worlds are finally speaking the same language. We're seeing technology refining itself for the most vulnerable populations, specifically pregnant women.
Which is huge.
It's a huge leap forward in equity and care. And at the same time, pharmacology is crossing over from type 2 to type 1 in ways that are fundamentally changing how we think about the disease metabolism.
And then you have the biology. We are going to talk about some things today that sound like pure science fiction.
Or maybe ancient medicine, depending on how you look at it.
Right. The gut.
The gut. The microbiome. We are finally going there in a serious, data-driven way.
It's a convergence.
It is. It's a convergence of disciplines. We're moving from a model of just replace the insulin to a model of manage the entire physiology. And the roadmap for today, I think, reflects that perfectly.
Okay.
We're going to tackle this in three main pillars just to keep it organized, because otherwise we're just going to get lost in the weeds.
Lay it out for us. What's the flight plan for this deep dive?
Pillar number one is precision technology. We have the new gold standard data on automated insulin delivery, or AID, specifically during pregnancy.
For a circuit trial.
That's the one. If you know anyone with type 1 who has been pregnant or wants to be, this is probably the most important segment for them.
And we also have some news you can use about sensors and airplanes in that section too, right? The practical stuff.
We do. Real-world applications. Then, pillar number two is adjunct therapies. This is the explosion of data regarding GLP-1 receptor agonists.
Semaglutide.
The drugs like semaglutide, specifically in type 1 diabetes.
This is the topic everyone is asking about. Can I take Ozempic if I have type 1? Is it safe? All of that.
Exactly. And we're going to look at new data that shows how these drugs reduce insulin needs, but crucially, how they do it independent of weight loss.
See, that's the part that blew my mind.
It's a massive finding. It changes our whole understanding of the mechanism.
It really does. It stops being about, vanity or BMI and starts being about metabolic correction.
It does. And finally, pillar number three, biological frontiers. We're going to the lab bench and into the clinic. We're talking about the gut microbiome, specifically the use of fecal microbiota capsules.
The pills, yes.
Yes, poop pills, and their potential to actually preserve beta cell function. And then we'll touch on some breakthrough work in stem cell maturation.
It is a packed agenda. I want to jump straight into the deep end with section 1, technology in critical contexts. And really, there's no context more critical or more high stakes than pregnancy.
Absolutely. And let's set the stage here, because I think unless you've lived it or treated it, it's hard to understand just how difficult pregnancy with type 1 diabetes really is.
I've had close friends go through it. They describe it as the Olympics of blood sugar management.
That's a fair description.
It's a full-time job.
Yeah.
On top of a full-time job with, the highest stakes imaginable. It's not just, I feel bad if I'm high. It's, I am affecting the development of another human being.
It is. Physiologically, it's just chaos. Let's break down the timeline. In the first trimester, a woman's insulin sensitivity often goes up.
So more prone to lows.
She's prone to severe hypoglycemia.
Yeah.
And she might be dealing with morning sickness, which makes dosing for food a nightmare. because she doesn't know she'll keep it down.
Right. You take insulin for a meal, you throw up the meal, and now you have active insulin on board with no fuel. That is terrifying.
It is. And then the placenta kicks in.
Hmm.
As the placenta grows in the second and third trimesters, it becomes a hormone factory.
Okay.
It pumps out cortisol, progesterone, placental lactogen, all these hormones that cause massive insulin resistance.
So his insulin needs just skyrocket.
A woman might see her insulin requirements double or even triple by the end of the pregnancy. She's fighting her own body just to keep blood sugar down.
And the targets are tighter than usual, aren't they? We usually talk about time and range being, what, 70 to 180?
For pregnancy, the international guidelines are much, much stricter. The target range is 63 to 140 milligrams per deciliter.
63 to 140, that's an incredibly narrow landing strip.
It is.
I mean, that's barely any room for error.
It is. And the reason is that high blood sugar hyperglycemia can lead to macrosomia, where the baby grows too large.
Right.
And this leads to difficult births, shoulder dystocia, high rates of C-sections. It can also cause neonatal hypoglycemia, where the baby's blood sugar crashes immediately after birth.
But on the flip side, if the mother drives her sugar too low trying to avoid the highs, she risks severe hypoglycemia, seizures, loss of consciousness.
It is a tightrope walk without a net.
Right.
Exactly. And for a long time, there was this hesitation about using the new tech, the closed-loop systems, the aid systems in this population.
Why? I mean, if the tech is so good, why not give it to the people who need it most?
Well, the algorithms weren't originally trained on pregnant women. The physiology changes so fast week by week that doctors were worried the algorithms just wouldn't keep up.
Oh.
They worried the targets weren't customizable enough to hit that 140 mil GDL cap. So the standard of care often remained manage it yourself or use a pump, but do all the math yourself.
But now we have the circuit trial, published in JAMA, which is, one of the most prestigious medical journals in the world. This feels like the answer we've been waiting for.
This is a landmark study. The circuit trial, led by Lois Donovan and her colleagues, it aimed to settle this question once and for all.
And they recruited women from where?
Across 14 centers in Canada and Australia. And they caught them early, which is key.
Right.
They randomized them before 14 weeks of gestation. You want to intervene early because that first trimester is so critical for organogenesis, the formation of the baby's organs.
So what was the comparison? Was it basically robot versus human?
Essentially, one group was placed on a closed-loop system, the Control-IQ system in this case, and the other group continued with standard care.
Which could be a pump or injections, just without the algorithm.
Correct. Without the automated algorithm making micro-adjustments every 5 minutes, both groups had CGM so they could both see their numbers.
So both groups had eyes on the data, but only one group had the AI driving the car. What happened?
The primary outcome was the percentage of time spent in that specific pregnancy range, 63 to 140.
And the drum roll, please.
The closed-loop group achieved 65.4% time in range.
Okay, 65.4%. And the standard care group?
They were at 50.3%.
Wow, that's a 12.5 percentage point difference.
In the world of diabetes clinical trials, we often celebrate a 4% or 5% improvement. A 12.5% difference is massive. It is statistically overwhelming.
Let's translate that into real life. What does 12.5% mean for a pregnant woman?
It translates to roughly 3 extra hours every single day that the mother's blood sugar is exactly where it needs to be.
3 hours.
3 hours where she isn't high, risking the baby's growth, and isn't low, risking her own safety.
And that's 3 hours where she presumably isn't thinking about it, right? Because the system is doing the work.
Exactly. The study measured glucose control. But the subtext here is mental burden.
Oh, absolutely.
Think about the cognitive load of correcting a high blood sugar.
Yeah.
You have to notice it, calculate the dose, administer it, and then worry for 2 hours if you took too much. The algorithm does that hundreds of times a day automatically. The relief must be immense.
Okay, but whenever we hand control over to a machine, the fear is safety. Did the algorithm get too aggressive? Did it cause more lows?
That was the big fear. But the safety profile was excellent. There was only one episode of severe hypoglycemia in the entire closed-loop group.
One in the whole study.
In the whole intervention arm.
That is remarkable given how aggressively they were targeting normal blood sugars.
What about DKA?
There were 2 episodes of diabetic ketoacidosis in the closed-loop group versus 1 in standard care.
Is that concerning? The numbers are so small, 2 versus 1, that it doesn't reach statistical significance as a safety signal. It could just be incidental. The authors concluded that the benefits vastly outweigh any risks.
So what was their final takeaway?
They stated clearly that these findings support closed-loop systems as a superior standard of care.
Superior standard of care. That is strong language.
hmm
It basically puts clinicians on notice. If you aren't offering this, you aren't offering the best available treatment.
And this aligns with another paper we saw this month, the International Consensus Statement published in the Lancet Diabetes and Endocrinology.
That was a massive effort.
Huge. It involved experts from 24 different medical societies. They reviewed all the evidence, including trials like Circuit, and they issued a formal recommendation. They emphasized that aid systems' automated insulin delivery should be used to optimize glycemia not just during pregnancy, but preconception and postpartum as well.
Postpartum is so often forgotten, but the hormone crash after delivery is just wild.
It is. As soon as the placenta is delivered, insulin resistance plummets. A woman might go from needing 100 units a day to 20 units a day, literally overnight.
And if she keeps taking the pregnancy dose,
She will have a massive hypoglycemic event. The algorithm adapts to that drop much faster and safer than a sleep-deprived new mother might.
so the verdict is in. If you are pregnant or planning to be, the tech is your friend.
The tech is your friend.
But
There's always a but.
we have to talk about trusting the tech. Because if you're going to hand over the keys to an algorithm, especially when your baby's health is on the line, you need to know the data is accurate.
Which brings us to the news you can use segment.
Exactly. And we have a fascinating, slightly unnerving study regarding sensor accuracy that came out in diabetes, obesity, and metabolism.
This affects everyone, not just pregnant women. I think every person wearing a sensor has had that moment where they feel like their device is gaslighting them.
Correct. This study by Withauer and the team in Switzerland looked at the Freestyle Libre 3. But the principle really applies to most sensors. What did they look at?
They looked at the difference between the current displayed value,
Yeah.
what you see when you unlock your phone, and the auto-log value that's stored in the data.
Wait, back up. Those aren't the same number. If my screen says 110, the data point isn't 110.
Ideally, they're identical. But this study found discrepancies. They showed that discrepancies exceeding plus or minus 10 milligrams per deciliter occurred in about 10% of cases.
10%. That's not insignificant. If I check my sugar 10 times a day, one of those times the number I see is wrong by more than 10 points.
Wrong is a tricky word. It's more about processing. The raw signal from a sensor can be noisy. It jumps around a lot.
Like a seismograph.
Exactly. If they showed you the raw data, you'd panic. So they apply smoothing algorithms. They average the last few points to give you a clean, readable number. They also use prediction algorithms to compensate for the lag time.
So the number on the screen is a process prediction.
Yes, but the autolog value might be closer to the raw point, or it might be processed differently. The team found that these discrepancies happen mostly during rapid glucose changes.
Like when you're crashing.
Exactly. Or spiking after a meal. Or during hypoglycemia.
Which, ironically, is exactly when you need the data to be the most accurate.
Precisely. Now, why does this matter for someone on a pump loop?
Because the algorithm acts on data.
Right. And in some systems, the algorithm might be looking at a slightly different data stream than what's being displayed to the user, or vice versa.
So I might look at my pump and see 95 and steady arrow, but the internal data sees 88 and dropping, so the pump suspends my insulin, and I'm sitting there confused thinking, why did it stop? I'm fine.
That's it. It explains those ghost-in-the-machine moments. It doesn't usually cause a safety crisis. I mean, 10 points isn't usually life or death, but it can cause a misalignment between user expectation and system action.
It's a good reminder that the sensor is an instrument, not a perfect oracle.
It is. And knowing this helps manage frustration.
Speaking of anxiety and technology, let's touch on one more real-world scenario, airplanes.
Ah, the fear of flying.
I feel like every time I go to a diabetes conference or scroll through a forum, someone asks, will the cabin pressure make my pump explode or overdose me?
It's a persistent myth, but it is based on valid physics.
Hmm.
We all learned Boyle's law in high school. Gas expands when pressure drops.
Right.
As the plane climbs, cabin pressure drops. If there's a tiny air bubble in your insulin cartridge, and there almost always is, that bubble will expand. In theory, that expansion could push the plunger and deliver extra insulin.
That's the theory. But does it actually happen in a dangerous way?
Well, we have a study this month also in diabetes, obesity, and metabolism, titled 8 at 30,000 feet.
Great title.
It is. They took 20 adults with type 1 on various aid systems, Minimed 780G, Omnipod 5, Control IQ, Camp Beast, and monitored them during actual mid-haul commercial flights.
I love that they did this on real flights, not just in some lab.
Exactly. It was a real-world test. They compared the flight days to ground days. And the verdict? Safe.
No explosion.
No explosions. And more importantly, no significant insulin delivery errors. The amount of unintended insulin delivery from bubble expansion was negligible,
So fractions of a unit.
if that. The aid systems handled the cabin pressure changes without any safety issues. Time in range and time below range were comparable to ground
So
days.
you can cross accidental mid-air overdose off your list of anxieties.
You can keep your pump on, stay hydrated, maybe avoid the sugary pretzels, but trust the device.
So we've established that the technology is robust. It works for pregnant women. It works at 30,000 feet. And the sensors have some quirks, but they're reliable.
But it's only one pillar.
It is. And frankly, technology is about management. It's about putting a Band-Aid, a very high-tech automated Band-Aid on the problem. The second pillar is where I think the biggest paradigm shift is happening right now regarding the treatment of the disease.
The pharmacological shift. We are moving from pumps to pens, or at least adjunct pens.
Correct. For a century, the equation was simple. Type 1 diabetes equals insulin deficiency. Therefore, the treatment is insulin. That was it. If your blood sugar is high, take more insulin. If you gain weight, take more insulin. Resistant, massive amounts of insulin.
And we're finally realizing that might be a blunt instrument. We're ignoring the rest of the metabolic orchestra. Everyone is talking about semaglutide Ozempic or Wegovy for weight loss.
It's a cultural phenomenon.
It is. But we need to talk about what it is doing for type 1 biology.
Because it is being used. Off-label, mostly, but doctors are prescribing it. And we have the ADJ Just T1D post-hoc analysis in diabetes care that sheds some serious light on this.
This is a crucial analysis. The ADJ-JJ-T1D trial looked at semaglutide 1.80 mg a week in adults with type 1 and obesity. The primary trial showed they lost weight and lowered their A1C. That's expected.
Right. If you lose 20 pounds, your insulin resistance goes down, your diabetes gets easier to manage. Simple physics.
But the researchers asked a deeper question. Did they use less insulin just because they were eating less and weighing less? Or did the drug do something to the diabetes itself?
Was it a calorie deficit effect or metabolic effect?
The analysis shows it is distinctly metabolic. The total daily dose of insulin dropped by a staggering 22.6%.
Nearly a quarter reduction? That's huge.
Yes. But here is the aha moment. They looked at the timeline. At week 4, just 1 month in, the participants hadn't lost much weight yet, maybe a pound or two.
Okay.
But 83% of that insulin reduction had already happened.
Wait, so the insulin needs plummeted before the weight fell off?
Precisely. The drop in insulin demand was almost immediate. Even at 26 weeks, when they had lost significant weight, statistical analysis showed that half of the effect was still independent of weight loss.
So what is the mechanism? If it's not, I'm smaller, so I need less insulin, what is the drug actually doing?
This brings us back to the alpha cell.
I forgot.
At the pancreas, beta cells make insulin, which lowers sugar. Alpha cells make glucagon, which raises sugar. In type 1, the immune system kills the beta cells. But the alpha cells are still there, and they're often dysregulated.
Like a gas pedal that's stuck down.
That's a great way to put it. They secrete glucagon when they shouldn't, especially after meals. So you eat a sandwich, your sugar goes up from the bread, and your alpha cells also tell your liver to dump more sugar into the blood.
It's a double whammy.
It is. And insulin doesn't always stop that glucagon secretion effectively in type 1. But GLP-1 receptor agonists like semaglutide do, they powerfully suppress glucagon secretion.
So they take the foot off the gas pedal.
Yes, and at the same time, they slow gastric emptying. They slow down the movement of food from the stomach to the intestine. This matches the absorption of food better to the absorption of insulin.
So you're attacking the high blood sugar from 2 angles. Less sugar dumping from the liver and better timing of the sugar coming from the gut.
Correct. And the study confirmed this. It showed that the reduction in insulin was primarily driving down bolus insulin, the mealtime insulin, not basal insulin.
That makes total sense. Basal manages your background needs. Bolus manages the food. If you fix the food spikes and the glucagon, you need less bolus.
It really changes the philosophy. It suggests that semaglutide isn't just a weight loss drug for type 1s. It is a glucagon management drug.
But this study was in adults. We know that obesity rates are rising in kids with T1D2. Is this safe for the younger crowd?
We have data on that too, published in Goiter this month. It was a retrospective study of adolescents aged 10 to 20 with T1D and obesity.
A really vulnerable age group.
Absolutely. And the results mirrored the adults. Their BMI-Z score dropped significantly, and their total daily insulin dose declined by 21.4%.
Almost the exact same number as the adults, 22.6% versus 21.4%.
Very consistent. And honestly, for a teenager, reducing the insulin burden and managing weight can be transformative for self-esteem and mental health, not just blood sugar.
It breaks that vicious cycle.
It does. But I have to play devil's advocate here. We see the headlines, gastroparesis, nausea, vomiting. And in type 1, there's always the fear of DKA risk.
Yeah, if people stop taking their insulin because they aren't eating.
Those are very real concerns. The nausea is real. It's the most common side effect. It usually subsides, but for some, it is intolerable.
And what about the long-term safety? Are we just trading one problem for another?
That is the million-dollar question. And we have a study from the Mayo Clinic Proceedings using the massive TriNetX database that looked at exactly this.
Okay.
They analyzed 2 years of data. They compared patients with T1D on GLP-1s against matched controls who weren't on them.
This is real-world data. What did they find?
The group on the GLP-1s had lower all-cause mortality and fewer hospitalizations compared to controls.
Lower mortality. That's a bold finding.
It is. And fewer emergency department visits. Now, it's observational, so we have to be careful about causation. Maybe these people were just more engaged with their health care. But it strongly suggests that these drugs are not harming these patients on a population level.
It suggests they might be cardioprotective.
Which aligns with what we know from type 2. These drugs reduce heart attack and stroke risk. Type 1 diabetics are at huge risk for cardiovascular disease. If these drugs offer that protection, plus weight management, plus glucose control, they are a triple threat.
We also saw a pilot study looking at combining GLP-1s with SGLT2 inhibitors.
The kitchen sink approach. SGLT2 inhibitors are another class of drugs that make you pee out sugar. They're great for the heart and kidneys, but carry a DKA risk in type 1.
But the pilot found that combining them with GLP-1s was safe.
In a small group, yes, and led to weight loss. It's early days, but it shows where we're heading, multi-drug therapy.
So if we summarize this section, we're seeing a shift where T1D treatment is becoming a cocktail. It's not just take your insulin. It's take your insulin and maybe this GLP-1 to fix your alpha cells and maybe this pill to protect your kidneys.
Correct. It's treating the whole metabolic dysfunction, not just the insulin deficiency.
But even that is still treating the symptoms, right? The downstream effects. If you want to talk about treating the root cause, we have to go deeper.
We have to go to the gut.
Section 3, the biological frontiers. And we promised we would talk about poo-pills.
We did. And I know it sounds crude, but scientifically, this is one of the most exciting areas of immunology right now.
The study was published in Gut Microbes. The technical term is autologous lyophilized fecal microbiota capsules.
Let's break that down. Fecal microbiota is the bacteria in your colon. Lyophilized means freeze-dried. Capsules means pills. And autologous means it comes from the patient themselves.
That's the part that confuses me. Usually with fecal transplants, we hear about taking stool from a healthy donor and giving it to a sick person. Why give a type 1 diabetic their own bacteria back?
That's a great question. The hypothesis wasn't necessarily about introducing new bacteria, but perhaps about stabilizing the community or influencing the immune system through the reintroduction process itself.
Okay, so what did they find?
It was a small study, only 10 individuals. But the design was clever. They had a run-in period before treatment. During that run-in, they measured beta cell function using C-peptide.
C-peptide tells us how much insulin the body is still making on its own.
Exactly. And as expected, during the run-in period, C-peptide was declining. The immune system was killing the cells. The disease was progressing.
Right.
Then they started the 3-month treatment with the capsules. And during that treatment, the decline stopped.
It flatlined.
It stabilized. The slope of the line changed. And then, in the follow-up period after they stopped the pills, it remained relatively stable.
That is incredible. So by manipulating the gut microbiome, they somehow told the immune system to back off the pancreas.
That's the implication. We know there's a gut-pancreas axis. The gut microbiome trains the immune system. 70% of your immune cells live in your gut. If the gut is inflamed, the immune system gets aggressive.
And those cells can travel.
They can travel to the pancreas. By stabilizing the gut, you might induce tolerance.
We also saw another study about repeated FMT from donors, right?
Yes, and that one was focused on complications, specifically diabetic gastroenteropathy, which is where the nerves in the gut are damaged. They found that repeated transplants from healthy donors were safe and effective at reducing those symptoms.
So we're seeing the microbiome as a target for both the cause of the disease, the autoimmunity, and the complications.
Exactly. It's a dual-use target.
But I want to understand the mechanism. How does a bacteria in my colon talk to a T cell in my pancreas? Is there a chemical messenger?
It's chemical. And a study in Nature Communications this month pinpoints a likely suspect: bile acids.
Bile acids. I thought those were just for digesting fats.
They are, but they're also potent signaling molecules. They're hormones. This study looked at 303 children and found a link between microbially conjugated bile acids and islet autoimmunity.
Microbially conjugated. Break that down.
The liver makes primary bile acids. They flow into the intestine. The bacteria get to work on them. They chemically modify them. They conjugate them.
So the bacteria are essentially manufacturing new chemicals using the bile as a raw material.
Exactly. The study found that children who developed type 1 had altered levels of specific conjugates. And these specific molecules influence the balance of T cells.
The soldiers of the immune system?
Right. You have Th17 cells, which are inflammatory, and you have Treg cells, which calm things down. The study suggests that specific bile acid derivatives promote Tregs. If you lack the bacteria that make those derivatives, you have fewer Tregs, and the Th17 cells run wild.
That connects everything. Diet feeds the microbiome modifies the bile acids train the immune system attacks the pancreas.
It's a beautiful, terrifyingly complex chain. But it gives us a target. It suggests that if we can just fix the bacterial factory, we might be able to stop the autoimmunity.
That is a massive concept. It moves prevention from immune suppression to gut restoration.
Precisely.
But while we're waiting for the perfect probiotic, what about replacing the cells that are already lost? We have to talk about stem cells.
We do. Stem cell-derived islets are the future of cure research. We can make them in a dish.
So what's the problem? Why aren't we all cured?
The problem is maturity. The cells we make in the lab often act like fetal beta cells. They're immature, they're sluggish, they don't have that sharp, rapid-fire response that an adult beta cell has.
You're lazy.
Not lazy, just underdeveloped. They lack the metabolic machinery. But a study in Nature Communications this month identified the missing link. They found these cells lacked mitochondrial transcriptional programming.
Their mitochondria, their power plants weren't running the right software.
Exactly. And they found a switch to upgrade the software. It's a nuclear receptor called PPAR-alpha.
PPAR-alpha?
The researchers found that if they treated these immature cells with a chemical agonist that turns on PPAR-alpha, it forced the cells to mature.
It forced them to grow up.
Yes. It improved their respiration, it fixed their glucose sensing, and they started secreting insulin, just like adult cells.
So we are biohacking the stem cells in the lab before we even put them in the patient.
Exactly. This is a crucial step. If we can make cells that work perfectly from day one, we don't have to wait months for them to mature inside the patient.
And if you combine that with the immunomodulation...
We saw another study suggesting blocking certain immune markers to prevent rejection. If you combine perfect cells with stealth technology, you are getting very, very close to a functional, off-the-shelf cure.
It really feels like the puzzle pieces are coming together. Let's look at the board. We have the tech to manage the glucose now.
The circuit trial.
We have the drugs to fix the metabolic background.
GLP-1s.
We have the gut interventions to stop the immune attack.
Microbiome.
And we have the engineering to replace the cells.
Stem cells. It is a multi-front war. And for the first time, it feels like we're advancing on all fronts simultaneously.
So what does this all mean for the listener right now? I mean, I probably can't go buy a stem cell patch or a poop pill at the pharmacy today.
No, but you can look at the news you can use from this deep dive. First, if you are pregnant or planning to be, the data is unequivocal. Fight for access to a closed-loop system. The evidence is on your side.
Right.
Second, if you're struggling with weight, high insulin requirements, or post-meal highs, the conversation about GLP-1s is no longer theoretical. It is worth a serious conversation with your endocrinologist.
Okay.
And third, take care of your gut. We might not have the specific prescription pill yet, but eating to support a healthy microbiome, fiber, diverse foods, fermented foods is likely playing a role in your immune balance.
And don't panic if your sensor reading is 10 points different from the download data.
Correct. It's a feature, not a bug.
I want to end with a provocative thought. You kind of alluded to it earlier. We're seeing these studies on microbially conjugated bile acids and GLP-1s improving heart health. Are we moving toward a future where we stop treating high blood sugar and start treating dysregulated signal processing? Like, is T1D eventually just going to be seen as a signal noise, problem noise in the gut, Noise in the immune system, noise in the alpha cells.
That is a fascinating way to put it. I think you're right. Future management won't just be about replacing the missing hormone. It will be about tuning the entire orchestra.
I like that.
We'll dampen the noise from the gut with microbiome therapies. We'll mute the alpha cells with GLP-1s, and we will amplify the beta cells with protection agents. We are moving from being plumbers, just fixing a leak, to being conductors.
From plumbers to conductors. And on that high note, we will wrap up this month's deep dive.
Indeed.
Remember to like and subscribe, follow the link in the channel description to buy me a coffee, and thank you for listening.